Well, we're now going to turn to another important domain of behavioral economics, which is healthcare. I think it's pretty clear that people do not behave rationally or fully rationally, both with regard to their health behavior and with regard to how they navigate through the healthcare system. And by the way, that applies not only to consumers, but also to physicians. So physicians don't behave perfectly rationally and are subject to behavioral influences also. We're going to hear from two speakers. We'll start with Saurabh Bhargavi from Carnegie Mellon, and then afterwards we'll hear from Kevin Volpe, and then again we'll have a discussion with the group. Thank you.
Yeah.
Great. Well, it's a real honor to be here. And Louise, thank you so much for inviting me. And it's a personal honor to be on a panel with Kevin and Peter. So I'm going to talk today about a topic that I think has been largely ignored in the public discourse over healthcare reform, and that is the question as to whether the recent expansion in the number of plan options that have been made available to enrollees, how that recent expansion has affected the quality of consumer choices. So the explosion in choice, I think, is most overtly evident in obviously the ACA, in which the median enrollee faces 47 plan choices, and then of course in Medicare Part D, where the typical enrollee faces about 30 choices. So a lot of choices, 2 to 3 times as many as a typical Republican voter, and so this can be rather. You might have intuitions about how overwhelming this could be. Now, the economic rationale for the expansion in choice, I think, was nicely articulated by Kathleen Sebelius, and she noted that more choice allows individuals to have a heightened likelihood of sorting into a more appropriate plan. It also increases competition and clout, and David and others have done a lot of work about this idea that the basis for this economic rationale that expanded choice is going to yield these benefits really depends critically on whether consumers understand and are able to make sensible choices among those that they face. So it's particularly difficult to, in the real world, unambiguously diagnose the quality of healthcare choices because such choices involve a number of considerations. So I'm going to talk about some results very quickly from a paper that I wrote with George Lowenstein and Justin Sidner, and we analyzed the decisions of 50,000 employees at a Fortune 50 company with a few attractive features that made it particularly powerful litmus test through which to clearly evaluate the quality of consumer choices, in this case employees. And so the first characteristic of this particular environment was that these employees were asked to build their own plan from a menu of 48 options by choosing one of 4 deductible choices, one of 2 coinsurance levels, 3 out-of-pocket levels, and 2 co-payments. And plans were otherwise identical apart from these differences in cost sharing and price. Now, a second important and attractive feature of this environment from a research perspective is that the plans were standardized in their presentation. And again, they were completely identical beyond these differences in cost sharing and price. So they had the same insurer, they had the same network configurations, same medical coverage, et cetera. So a third feature that makes this setting particularly useful, again from this research perspective, not so good from the employee perspective, is that the way in which these plans were priced implied that regardless of how much spending you have, which is listed here on the x-axis, choosing the $1,000 deductible would yield a lower overall out-of-pocket cost, regardless of how many expenses you had, relative to the otherwise equivalent plan with the with a lower deductible. So here you can see in this price schedule that, if you take a lot of vaccines and get really sick, according to some people, and you're on the right side of this graph, it's going to be cheaper for you to have the $1,000 deductible. If you have no utilization at all, it's going to be cheaper for you to have the $1,000 deductible relative to these other otherwise equivalent plans with lower deductibles. So this is a very unique setting from which, again, to see how employees did, given this menu of choices, of which 35 of the 48 choices were financially dominated in this manner. So how did employees do? Well, I think a lot of you, certainly based on the talks today, might have a strong intuition that they actually didn't do that well. A majority of employees chose financially dominated plans, and what this implied was, on average, the 36% of employees, for example, who chose a $500 plan in lieu of the otherwise equivalent $1,000 deductible, ended up paying $630 in annual premiums to avoid $230 in expected costs and a maximum of $500 in expected costs. Now, the claim, I think, or one important way to characterize, or useful way to characterize the size of these costs is that on average, for those choosing these suboptimal plans, the excess spending on an ex-ante basis, so relative to the otherwise equivalent $1,000 plan, was equivalent to 42% of annual premiums. So this is a magnitude that I think is far larger than the other issues that have gained a lot of traction in policy discourse. From a policy perspective, what's particularly worrisome is that low-income employees were more likely to select these dominated plans, and employees did not correct their plan choices the next year. So this begs the question of what was going on? Why did employees make these costly choices? So we conducted a series of experiments using several thousand online subjects, and we presented them with stylized and slightly simplified plans that were populated with the same prices and features of those plans faced by the employees. And we manipulated these hypothetical plans in such a way to allow us to test for three candidate explanations for this, for these poor choices. Now, the first thing that we tested was whether poor choice was due to the size of the plan menus or the complexity in the rather idiosyncratic choice interface. We also tested the possibility that poor choice was due to a low search motivation, or perhaps people kind of had too much faith in their employer in terms of presenting them with actuarially priced options. And then we tested the role that low health plan literacy might have played in these choices. And so what we found surprised us a little bit. It wasn't that people were overwhelmed by the number of options that they faced. In fact, we found the same pattern of choices approximately when individuals were given a simple menu of 4 plans that only varied in their premium and deductible, and again, were otherwise equivalent. And again, in that setting, we found that a majority of subjects chose the financially dominated options. So what we concluded was that from these studies, and Kevin and others, David, have done work showing this as well, is that there's this pervasive lack of fundamental health plan literacy, whereby many individuals, many adults, can't define deductible or copay or these basic cost-sharing features, which makes very basic plan comparisons difficult. So I should say that we found that employees did not choose randomly. And in fact, I think this is a rather striking demonstration of the non-randomness of the behavior that we saw. So in the lab, which is on the left, we see more or less the same distribution of deductible choice as we did in our actual employee sample. So I won't go into too much detail. Given the theme of complexity, I thought I would have one inscrutable slide. But in ongoing work, we're trying to understand kind of the decision theories that are underlying how people are making these choices. And one, I think, possibility that's gaining a lot of support from some of these studies is this idea that people recognize that plans have a gradation in the generosity of their cost sharing. People also recognize price differences. And so what people do based on this recognition is potentially sort themselves into plans based on the available menu and some understanding of their health needs. And so we've tested menus where we've added extreme and unattractive, irrelevant options, and we found that these additions really change the distribution of plan choices. Taking some of these findings and translating them into a policy setting, certainly the architects of the ACA weren't ignorant of the complexities of choices, and they instituted a number of different measures to help facilitate choice, beautiful videos on these websites, a clean interface, and notably, they introduced a metal tier structure that organized plans into their actuarial value. I don't know, Peter, if you were responsible for that, but there were a lot of efforts designed to help organize and facilitate choice. So in another paper, what we did was we analyzed the pricing and the features of 70,000 of the plans on the exchange, and what we found was that the choice of plan tier was highly consequential in the ACA, whereby if a consumer chooses a plan that's incommensurate with their medical needs, they could end up spending what would amount to about 60% in addition to their annual premium, just due to increases in out-of-pocket costs relative to kind of the optimal tier choice. And a second piece of the study was using these same hypothetical choice settings, we tested whether the metal labels actually increase the quality of choices. And what we found was that, in fact, they didn't. And they performed, subjects facing these metal labels performed slightly worse than had they just been faced with plans that were generically labeled, so Plan A, Plan B, Plan C. So I'm going to end by just suggesting that these studies and many others suggest that in this environment with growing complexity, not only in financial choices, but certainly in health plan choices, there may be certain limits to traditional nudges, so to this idea of using marketing interventions, informational disclosures, education interventions. We found these limits in our work, and others have in theirs. And so perhaps a strategy is to move beyond the simplification of the choice environment to actually fundamentally simplifying the underlying choices themselves, so simplifying the incentives and the structure of insurance. Yeah, I think I'm over, so thank you.
Okay, well, before starting, I want to thank David Wessels, the Hutchins Center, and Brookings for giving me the opportunity to participate in what's been a really interesting dialogue. We are in the midst of really, I think, an unprecedented sea change in how healthcare financing is funded in the U.S., as highlighted by this recent announcement that for the first time really laid out specific goals in terms of shifting away from fee-for-service towards alternative payment models, and in essence, shifting the underlying incentives for physicians towards keeping people healthy as opposed to just treating them when they're sick. Now, one of the challenges to succeeding in this model is that we have very high rates of unhealthy behavior in the U.S., and there are lots of statistics like this, as you probably know. About 70% of our population is overweight or obese. Smoking remains the leading cause of preventable mortality. Lots of spending tied up to chronic disease and acute exacerbations of chronic diseases. So when various people have tried to estimate causes of premature mortality in the U.S., the percentage that's attributed to behavior is pretty high. And generally speaking, the healthcare delivery system, health plans, employers haven't done a great job of figuring out how to make the population healthier. So as you know, we've been on an interesting journey in terms of trying to better understand people's behavior and developing tools for more effectively influencing it. And in some sense, part of the challenge I see in the success of these new healthcare financing models ties to the fact that when you think about where the health delivery system is, it's really still sort of stuck in the information age, where most of the encounters between clinicians, patients really rely very heavily on just providing information and then hoping the patient will follow suit. A lot of employers and health plans are obviously trying to influence people through the use of financial incentives. About 85% of large employers in the US now use incentives for health behavior of one kind or another, but these incentives tend to be really standard economic incentives, and a lot of those programs are not particularly effective. Very few entities are really using insights from behavioral economics and taking advantage of many of the learnings in terms of understanding people's present bias, the power of framing effects, the importance of regret aversion, loss framing, social context, choice architecture, inertia. So I think all of this really highlights that there's a lot of potential for us to do better, but we still have a long way to go. And I'm going to give you just a few examples of how we've been trying to apply some of these concepts in practice. So the first example comes back to the concept of choice architecture and defaults. And this is a famous slide of some work by Eric Johnson and Noah Goldstein that basically just documented rates of organ donor registry by people in different Western European countries. These are sociodemographically very similar countries, and the big difference between them is the countries in yellow on the left are countries where you have to opt in to be on the donor registry list. The countries in the right in gray are countries where you are presumed to want to be on the list and have to explicitly opt out. And I don't need to tell anybody here that these are the kinds of differences in effects that are very difficult to achieve by any sort of intervention, and I think parallel much of the nice work by David Leibson's group in terms of retirement savings and the effects that have been observed. Now, you may wonder, how does this apply to various healthcare settings? And I think it could apply in a lot of settings, and people are gingerly exploring how this might be done. This is an example of gingerly exploration that was led by one of my colleagues at Penn, Scott Halpern, who's a critical care physician. And he looked at this question of terminally ill patients and the kind of care they get at end of life. As you probably know, it's well known that in the US we tend to be overly aggressive in treating people who have terminal lung cancer, for example. And so what Scott did in this study is he took a panel of such patients where there was pretty clear consensus that their disease was not treatable, and he randomized them to different kinds of defaults in terms of advanced directives. One type got a prioritize my comfort type default. Another had a do everything you can to keep me alive as long as possible type default. And the third group was randomized to let my family members and my doctor decide later, which is in essence what typically tends to happen now. And you can see the rates here varied quite a bit. 77% in the comfort-oriented default shows a comfort-oriented plan of care, 61% in the standard approach, 43% in the life extension default. And I think this is very important because it documents in some sense what is likely happening in healthcare delivery systems around the country now, but which people aren't systematically aware of. And it highlights that both in terms of describing what happens and thinking about how we might think about interventions in the future, the degree of differences here are important, and it's important to carefully consider how this could be delicately deployed. Now, it's not always easy to deploy these opt-out type defaults, and here's another example where we used a different type of approach. This was in trying to take on the challenge of medication and non-adherence, which is a big problem for chronic diseases, particularly asymptomatic chronic diseases. And CVS Caremark had developed a plan. There was an automatic refill program. They thought it was self-evident people would sign up for this because it would be so much more convenient than having to refill 10, 15 medications on your own each month or every 90 days. So they were disappointed when enrollment rates in this program were lower than they had hoped. They asked us, could we do this some other way? We asked about opt-out defaults. They said impossible. Every time one of these credit cards goes out, we have to charge people. They'll be very upset if defaulted into it. So we used active choice here. We made it easier for people to decide. We simply highlighted the advantages in terms of convenience to signing up, disadvantages of doing it yourself, and more than doubled the rate at which people signed up. So this is a simple example of how that can be used. Now, in terms of thinking about incentives, there's a lot of different ways these can be deployed. There's a section of the Affordable Care Act, Section 2705, that allows employers to use 30 to 50% of premiums for penalties or rewards tied to outcome-based incentives. But one of the limitations is most employers do this by simply rolling this into premiums. And for some of the mental accounting issues that people have alluded to earlier, that's not a very effective way to change people's behavior. This was an early demonstration we did of pulling the incentive out of premiums, providing it as a separate reward. This was done among employees at GE, roughly tripled rates of smoking cessation. We tried to push that forward in terms of thinking about time and consistent preferences, people's willingness to put some of their own money up front, risk it if they weren't successful in quitting smoking, matching it generously if they were, in looking at uptake and effectiveness of pre-commitment or deposit contracts. What we basically found here among employees at CVS is that among populations, a standard reward approach is actually more effective than giving people the opportunity to put their own money at risk. Because the underlying problem is that everybody will sign up for a reward that's upside only. That's what you see in this graph. Among those people, about 17% of people quit. If you give people the opportunity to put their own money at risk, even if it's very generously matched, most people will not do it. Only about 14% of people in this case signed up. Among those people, we had a 52% quit rate, but the uptake rates are too low using the current approaches to really make that effective. Now, what we did with CVS as a next step was interesting because they said, all right, one of the conclusions was maybe we should do another research study, and that really wasn't what they were looking for. They said, all right, let's take your findings. What should we put in the field now? And what we came up with was, in essence, the inference was we need to lower the barrier to participation in these types of pre-commitment deposit contracts. We lowered it from $150 to $50, and we made the match more generous. So we raised, the match was effectively a 14-to-1 match, 700 good reasons to quit. They rolled this out at the same time we published that paper. It's now in play for CVS employees nationwide. We're very interested to see what happens both in terms of uptake rates and effectiveness. So it's important to think about these opportunities in terms of employer incentives to try to influence behavior not just by adjusting premiums, lots of different ways to do it, taking advantage of behavioral biases that we think can be more effective. Finally, I want to comment briefly on some of the changes in terms of healthcare delivery. In essence, we have a 5,000-hour problem. Even if you go to the doctor, a lot of times you might spend 7 minutes with them, so it only adds up to a few hours a year. 5,000 plus waking hours where you're on your own. And there are a lot of opportunities to think about these changes in health financing, the advances in technology and behavioral science, and how that could be used to better influence population health. There are a lot of systems like this that are evolving. This is an example of one we built at Penn with NIH support, where we have lots of different types of wireless devices in people's homes. They upload data to a server depending on what sort of research program people are in. They get feedback. Feedback comes by email, text, IVR, goes to a patient, social supporter, peer mentor, through an exception handling process, a provider. And all that, of course, can be manipulated. Funds can be transferred electronically to people. And what we've been doing is try to solve this problem of medication adherence after a heart attack. One of the shocking statistics in American medicine is that in the year following a heart attack, people are only adherent 40 to 45% of the time to their cardiovascular medicines. This is an approach funded by the Center for Medicare and Medicaid Innovation, where we've put together a bundle of different approaches, wireless technologies, daily lottery incentives, social support with automated notification when you miss your medicines, and then a process for contacting people and their social supporter if you really start missing a lot of medications. About 1,500 participants, 45 states. So far, relative to the implicit baseline of 45%, we're seeing really good adherence rates. We'll see if it makes a difference in terms of rates of adverse events and hospitalizations. So moving towards the future, I think what we had as of 2014 was a reactive visit-based model of care, largely as a reflection of the fee-for-service financing that drove the creation of that. Providers had very little data from outside of their clinical encounters to guide their decision-making, and the limited telemonitoring that existed really consisted of giving patients devices on somewhat rare occasions and then hoping they would use them. Where I think things are going is a more proactive, non-visit-based model. The degree to which this will happen largely depends on these shifts in health financing. I think we'll have a much more sophisticated system of automated feedback informed by machine learning, of feedback to patients and providers of who the high-risk patients are who need your attention when they're not in front of you. But one of the key elements here is really going to be to fill in a lot of the pieces in terms of behavioral economic strategies around engagement, because the patients in whom there's a need from a health and economic standpoint to improve behavior are typically patients in whom it's difficult to get them to engage with interventions, and that's where I think a lot of this work can be helpful. Thank you.
Okay, I think I'm going to exercise the chair's discretion, and we'll end at 3:15 instead of 3:10, given that we ran over a little bit on the previous one. Let's start with, hold on a second. Sure. There we go. Let's start with where Kevin wound up, because we saw on the chart with regard to poor decision-making with regard to insurance choice and income gradient to the share of people who were making bad decisions. And then in the smoking cessation study, I remember, you didn't show it, but I do remember that in one of the appendices, it was also the case that the reaction was stronger to the intervention among higher earners than lower earners. So there's also an income gradient or earnings gradient to a lot of that. Work that Louise and I did as part of a National Academy of Sciences panel that was released yesterday suggests very steep an increasing gap in mortality or life expectancy by socioeconomic, in particular by earnings over time, which is presumably reflecting behavior more than anything else. So I guess the key question is, how do we, coming back to David's point earlier about some of this seeming paternalistic or too interventionist, how do you avoid the assertion that what you're really trying to do is fix poor people's bad decision-making and have these interventions not come off as paternalistic precisely because it appears that they're most effective in many cases for lower income or less educated people?
Well, it's a very important question. I think the appendix you were alluding to, Peter, we showed in people who put voluntary deposits, they were more likely to put them down if they're higher income. But in general, we find these types of incentive programs are more effective in lower income people, and particularly lottery type incentives tend to work better in lower income people. But it's a tricky issue because I think everyone's wary of designing programs that are seen as overly paternalistic. And, it gets a little bit into these tricky questions of, when is an incentive a nudge and when is it more of a shove? And part of it, I think, really depends on the magnitude of the incentive. It also partly depends on the nature of the program and the sense of, how many of these people really want to change this behavior as opposed to how many people are changing it because they're given access to this incentive. And with smoking, it's an interesting case because it's pretty well documented that about 70% of Americans who smoke want to quit, but everyone knows how difficult it is, and only about 2 to 3% per year actually do. So when you look at the disparities in health that emerge from the higher rates of smoking among lower income people and the pretty grave consequences in terms of higher mortality rates, higher morbidity rates, I'm comfortable with the fact that the incentives do work better in lower income people because I think they may help to ameliorate some of those disparities. And I think given the voluntary nature, they're not overly paternalistic.
So another question involves your interesting findings that basically it's not about simplification, at least in that setting. Even if you simplify the choices, people still make poor decisions. And so I wanted to just tease out a little bit more your suggestion at the end that we effectively auto-assign people to plans, or that we do, I think you used customized actuarially based recommendations. Somehow either suggesting or opting people into plans that look like they would work better for them. There are multiple different opportunities to do that kind of thing in Part D, in the public exchanges, and so on and so forth. Part D, as you probably know, for the dual eligibles already does auto assignment, but it's not customized. So how in particular would you do that when you don't know take someone new to Medicare, you don't have the past history of what their utilization patterns are like? Would you update this over time, or how would you do it, especially for new entrants, onto like a public exchange where you don't actually have their past history?
I wish Kevin would have gotten this question. I think it's a bit above my pay grade. So I think one of the implications, and we're trying to work through kind of the implications and how they might differ across different policy settings, is that certainly in the case of healthcare choice, we have, I think, really strong evidence now of this pervasive lack of basic understanding. And so there we have a environment where a lot of the real-time interventions that I think have had more success in other domains of financial choice, at least in some of the work that we've seen, has had some success, but doesn't really bridge the gap in terms of really repairing choices. And so the thought was there that more aggressive sets of interventions, like restricting menus or smart defaults, or decision aids that broadly kind of accentuate the trade-offs that are relevant for this particular decision, would be of use. I think the last kind of throwaway line that I had made was kind of the thesis of a paper that George Lowenstein and I wrote about the possibility of, and David and Kevin have an earlier paper kind of making this point as well, about the possibility of simplifying the underlying structure of the incentives in insurance, so getting rid of deductibles or co-payments and co-insurance. And David, I think, has made this point a few times, and Raj made this point earlier, that the kind of hedonic or the experienced, the survey data that we have from people exposed to these types of plans suggests that people want simplification in terms of their marginal incentives for health costs. And so I was in New York in the summer, and I don't know if you're familiar with this, but Oscar is a new...
Never heard of it.
Oh, okay. No, I mean, yeah. Imagine a lot of people are familiar with it. Oscar is a new kind of startup, and they, I think, position themselves as the Uber or Airbnb of healthcare. And what they're doing is they're leveraging a lot of these insights, and they've actually come out with plans without deductibles and co-payments. And so I've asked them for all their data and to run experiments, and they were, I think they're thinking about it. But I mean, that's exactly kind of the, I think that's exactly it's a nice model. I don't know if it will work. I mean, we'll see from the evidence, but people seem to like it, and it seems really intuitive.
All right, let's open it up to the audience. We'll start over here.
Hi, Jeff Sandler again. Just to build on the comments about Oscar, I think some of the things that Oscar is if you want to say pioneering right now, have been in existence for a long time under the, I guess, what a lot of people would know as value-based insurance design, where maybe it's not across the board, but if you think about where the drivers of healthcare costs are, and we're not talking about trying to help individuals make decisions that lower their out-of-pocket costs, but what do you do to make the system itself more cost-effective? That some of these designs that Medicare is adopting now, and you're seeing more in the private sector, particularly among large employers who started down that path a number of years ago, have targeted the more resource-intensive and expensive medical conditions like diabetes and so on, and targeting a benefit design that lowers the financial barriers to people getting preventive and care management treatment, that they need to hold those costs down and avoid more expensive medically adverse consequences farther on. There's been a lot of development there, and I think we're going to see a lot more of that in the future. And to get back to some of your earlier comments, I don't I think that to design a program like that, you don't actually have to know in advance who needs it or who doesn't need it. If the design makes sense and it provides the opportunity to manage those most expensive conditions where the savings in healthcare dollars are really going to be, then that's sort of the optimal way to go, I think.
So just to turn that into a question, your focus is really on the premium and the copayment, but there is the potential to vary the copayments in particular across different types of interventions. Medicare Advantage has now put out some proposed regs, or maybe their final regs, to allow private insurance plans within Medicare to experiment with value-based insurance design, work that you've done also. So how should we evaluate? I mean, there's only limited bandwidth for policymakers to make a bunch of changes, so how important is it to change the kind of premium mistakes that people are making versus moving along the value-based insurance design dimension? That might be for actually both of you.
Well, it's an interesting question. And I think a lot of the application of value-based insurance design to date has been very limited. It's been limited to medications, and it's been limited to lowering barriers to what's perceived as high-value services. What I think is actually really needed when you look at the spending in healthcare and the fact that so much low-value care is provided is much higher cost sharing for low-value care. But this is where it gets complicated, because there are some services that are low value for everybody, but whether a given service like a stent in your coronary artery could be low value for a patient with stable angina. It could be life-saving for a patient who is having an acute MI. So that's where I think it gets difficult to come up with benefit designs that are nimble and in real time can actually act without clogging down the system. I don't know how to answer Peter's question. I mean, some of the things that, Saurabh, like the slide that struck me the most was the one where he showed the 48 different choices, and you just think, my God, how do they expect all their employees to go through all 48 choices and really weigh the trade-offs? And I think some very simple things could be done, a little light paternalism, like winnowing that down from 48 to 6, 5, something like that. I mean, it seems like some of those changes wouldn't necessarily require any governmental intervention. It sort of seems like common sense. But it, of course, raises the question of why do they provide such choices? And
right.
Maybe evidence like the evidence you're generating will help make people more aware of that being more choice, not necessarily being beneficial.
Well, and again, to the extent that the number of choices, which was not, didn't look like it worked that well unless you're narrowing it to a particular set. To the extent that matters, it is interesting because we're having this whole other discussion in competition policy, the Daphne et al. Findings that the number of plans on an exchange seems to affect the premium. To the extent that there is a trade-off with complexity and this sort of dynamic, that premium reduction on average may not actually be beneficial if it's also inducing people to choose even more poorly. So I think that's an open question. There was a question back.
Harvey Galper. I had a question relating to, again, the choices that people make and why they're not very good. And wondering whether if you could set up certain profiles, if you're in this situation, you tend to spend this much,
Right.
then this might be a plan that you should consider. So you could kind of try and frame some of the choices for them in terms of what different profiles would look like for different people, and then they might figure out what plans would be most appropriate for them.
Yeah, no, I mean, I think that's a terrific idea, and it goes back to this point of kind of accentuating, I think, the trade-offs that are relevant for this kind of choice. And I think what we found, and others have tried to look at simulated choices in these hypothetical environments. It's really difficult to get individual level data on choices. Peter, I don't know if you can do anything about that. But so all the evidence that we do have, at least with respect to the ACA, is with kind of indirect evidence and then these hypothetical choice situations. People have tested, and we've looked at scenario-based educational interventions. It seems to work. So as an example, in this dominated choice paradigm that I discussed, it brought up the number of, let's say, correct or judicious choices from about 40% up to 65%. There's a lot of heterogeneity whereas those of lower literacy and education and those that actually have self-perceived high health risks tend to go for the low cost sharing and low deductibles. So again, it's a situation where, to Kevin's point about winnowing down the choices in this particular environment to 6 choices or 4 choices, I mean, we gave people 2 choices with plans that only varied in their premium and deductible, and we still saw nearly half the people choose a dominated option. So it might be a context-specific set of approaches, and this is one with just this kind of fundamental complexity that is difficult to deal with.
The only thing I'd add, and then we'll go to Hank for a final question, is as the system digitizes, including clinical data, you can imagine, it's not hard to imagine, you can imagine being able to submit your EHR or EMR to an algorithm that will then return what the best insurance policy is for you based on what conditions you have and what the projected evolution of those conditions, et cetera, are.
And I would say that some states, I think 5 states actually have their own calculators that they're using for that purpose.
Hank.
This is a question to whoever might be able to answer it. The evidence you've reported is that from people are confronted with a set of choices for insurance. We confront their choices with a model to evaluate those choices, which is based on the traditional economist's paradigm, which is cost minimization. They're making the choices they're making, and there are 2 broad possibilities. One is it's just random noise. They really are just doing things for no particular pattern or reason. But the other is that there is some underlying rationale that is governing those choices. And another way to go at this is to try and figure out what, if you will, the utility function or the decision framework is that they're actually bringing to the table. And if we understood that, we'd be a long way toward, first of all, being able to evaluate whether maybe the original framework we judged them on was incomplete. And secondly, if we conclude it isn't, how effectively to nudge or regulate or develop AI software to help them or whatever to improve the decisions. So the question is, do you know of any successful or unsuccessful efforts to decode what the decision framework people are actually bringing to the table is?
So as a first stab, I think that's a really insightful comment. So I think the really unique aspect of this research, and there have been so many demonstrations that people are making what look like fairly inefficient health plan choices. The really distinctive feature of this setting is that the choices that we see cannot be explained by any set of risk preferences or any distortions and beliefs about healthiness. So and I don't know how convincing those stories are in these other settings, but so it is clear in that sense. I think you raise a really great point that if we take seriously these choices, certainly there are accounts that suggest that there's hedonic pain associated with an out-of-pocket dollar that's expended, whereas a dollar deducted from your payroll might not be associated with that same pain. There are budgeting, or there's some attractiveness to having a low variance set of future expenses, and there are budgeting considerations and liquidity considerations that I think could create some wedge between out-of-pocket expenses and payroll deductions. I don't think they're large enough to explain the patterns that we see, particularly in light of all this confusion that David and Kevin and others have demonstrated that people have with defining a deductible.
Anecdotally, it seems like a lot of people who choose dominated low deductible plans say, I don't want to have to worry about out-of-pocket expenditures if I or somebody in my family is going through an illness. There'll be enough stress to deal with then. And it would be useful to see if there's some way to circle back to people and see, is that worth $600 to you? Because if that's a major driver, it'd be good to see, quantify how much that's really worth to people.
I think Victor Fuchs made that exact point decades ago as one of the reasons why people carry heavier insurance than we think may be optimal.
So in our example, one of the stylized facts is the individuals who chose a $500 deductible, were paying $630 to avoid an expectation $230. So our kind of ongoing work is examining exactly, or trying to pin down exactly what the psychology is that's motivating this choice. And I think it's exactly, or very close to what Kevin described.
So the mark of any discussion is that the moderator gets up and cuts it off before it's done. So I'm going to do that. We're going to take a 10-minute break, and I really hope you'll come back. We're going to try and make the next panel more interactive. There's no presentations, and the rules will be that you can ask a question of anybody in the room, not only the people on the panels. A number of the speakers will be with us for that, so I hope you'll stay. Coffee, bathrooms,